Can we have the next speaker, Dr. Lavanya, speaking about a case of cryptococcal scleritis, which is mimicking Scleromalacia perforans.
Good morning, everyone. I'm presenting a case of cryptococcal scleritis mimicking Scleromalacia perforans. 83-year-old male patient, farmer from a low socioeconomic background, presented with complaint of redness and mild pain in the right eye associated with occasional discharge for 3 months. There was no history of trauma and no known systemic illness. On systemic examination, patient was found to have high fasting blood sugar levels and was diagnosed with type 2 diabetes mellitus and was started on medication. Coming to the ocular examination, the right eye had best corrected vision of 2/60. There was a 3 into 2.5 mm epithelial defect in the cornea with limbal stem cell deficiency and perilimbal thinning. And in the sclera, there was scleral thinning noted in the infratemporal quadrant as seen in the picture. And lens PCIOL was present and fundus was normal. Left eye findings were normal. Investigations in systemic investigation, routine blood investigations were done and it was normal except for elevated blood sugar level, and rheumatological and immunological profile was negative, and imaging showed normal study. And coming to microbiological investigation, conjunctival swab was sent from both the eyes which revealed no growth, and scraping was sent from the site of the lesion and it was negative for both bacterial and fungal. Despite extensive systemic and ocular investigation yielding normal results, patient didn't show any signs of improvement with the topical antibiotics, steroids, and lubricants. So a diagnosis of right eye scleromalacia perforans was made, and patient underwent right eye amniotic membrane grafting with glue and sutures as seen in the picture. On 2 weeks follow-up, patient had symptomatic relief and best corrected visual acuity was 6/60. But when the patient presented at 1 month follow-up, there was worsening in the inferior and the inferotemporal scleral thinning, and along with the overlying remnants of AMG and suture. So patient underwent right eye scleral patch graft under general anesthesia because of the risk of perforation under block, and scleral tissue sample was sent for histopathological examination, which revealed cryptococcal species. These are the histopathology images. First slide shows the HND staining in 20x magnification, characteristic granulomatous inflammation with giant cells, and GMS stain with under 40x magnification, which shows the brown-black round or oval structures of different sizes, characteristic of cryptococcus. Diagnosis of ocular cryptococcus scleritis was made, and patient was referred for systemic evaluation to know the focus of infection, but there was no abnormality, and patient was started on topical and systemic antifungal agents, and there was complete resolution of ocular symptoms. Cryptococcal discussion. Cryptococcal infection is generally caused by Cryptococcus neoformans. It is an uncommon infection, but is generally seen in the individuals who are immunosuppressed, mainly HIV patients, but can also be seen in organ transplant individuals and uncontrolled diabetics. It generally occurs as an asymptomatic pulmonary infection in immunocompetent individuals. And contact with the PG excreta is an important predisposing factor. And the most common manifestation is papilledema due to central nervous system involvement, including other manifestations like optic atrophy and extraocular muscle paresis. And chorioretinitis and endophthalmitis are usually blood-borne infections in immunocompromised individuals. There are case reports of cryptococcal uveitis presenting secondary to meningoencephalitis, even in immunocompetent individuals, and cryptococcal keratitis after keratoplasty was also reported. There are reports of cryptococcal infection presenting as granulomatous conjunctivitis, but to the best of our knowledge, there was no previous reports of isolated primary ocular involvement of cryptococcal infection. Conclusion: cryptococcal infections involving the ocular surface can exhibit clinical manifestation resembling inflammatory scleritis or Scleromalacia perforans. So distinguishing based on the entities is crucial due to difference in the management approaches in between the two. These are my references. Thank you.
Thank you. I think it's a well-managed case. Only thing, if it was a progressive condition in the first time when the patient was taken for the AMG, maybe at the same sitting a scleral biopsy could have been done, because anyways the patient was taken under the operating table. But otherwise, I think it's a well-managed case.
Thank you. Just one point. How would you make the distinction that this is not secondary to the surgery and it's a primary cryptococcus scleritis? Is it possible that post-surgery this is a secondary infection?
No, sir, like previous swab and all were taken already. Previous scrapings were also sent, so it was negative at that time also.
So scleritis can be negative and may need multiple scrapings because of the nature of the tissue. And otherwise well managed, when you mention cryptococcus spores, not cryptococcal. Okay. Cryptococcal is in the context of uveitis, scleritis, but otherwise it's the microbiology, correct?